final surgeon speaker of the morning, which is Mr. Edward Peng. He's a congenital cardiothoracic surgeon in Glasgow. He's trained across the UK and has also done some of his training in Colorado, in Denver. So I'm looking forward to hearing all about congenital surgery. Thank you, Ed.
Okay, Farah, can you hear me? Good.
Yes, we can. Thank you.
Thank you. Well, thanks to Farah for the generous introductions. And thank you to the Society for the invitations. I think it's been a great honor for me to be able to introduce congenital heart surgery. And I think it's simply a pure joy for me to speak to all the aspiring surgeons. So today I'm talking about caring for children needing heart surgery. And I'll cover the following aspect. So first and foremost, I think, why do children need heart surgery? Putting a child through a surgery is not a minor undertaking, let alone an open heart surgery. Therefore, you must have a very strong reason, I think, to put a baby under the knife, stopping his heart. And you must have a very good reason to the family to do so. So now let's take a look at this slide. It's based on the WHO report in 2015. And it says that there were 2.5 million neonatal deaths in 2015 due to congenital malformations of all types. And the common severe congenital anomalies with the heart defects, neurotube defects, and the Down syndrome. And among these, the most common birth defect will be congenital heart malformations, and traditionally, we quote about 1% of all live birth. And in this global study funded by Bill and Melinda Gates Foundations, there was as much as 1.8% live birth, which presented with congenital heart disease in 2017, which accounted for nearly over 250,000 of deaths around the world, mostly under the age of 1, making it the top 5 causes of neonatal death. And unfortunately, most of them, as you can see, occur in a low income country shaded in red. So therefore, the most common reasons a child needs heart surgery is due to a defect they were born with. And the most important or primary indication for surgery is to achieve survival for them. And hopefully with that, to help them to live normal or close to normal life if possible. And looking just over 50 years ago, less than 1/3 of infants born with congenital heart disease will survive to adulthood. But currently, impressively, the inverse is true. The other reason of why a child might need heart surgery is due to acquired heart lesions. For instance, cardiomyopathy leading to heart failure can be a result of a viral myocarditis, nutritional deficiencies such as vitamin D, or commonly idiopathic dilated cardiomyopathy. In developing countries, rheumatic heart disease is the leading cause of cardiovascular mortality, the complications of a rheumatic fever from group A Streptococcus pyogenes. And the areas shaded in yellow were the endemic areas. And in 2018, the declarations was made by the international community in Cape Town to improve access to life-saving surgery to this patient with rheumatic heart disease in the developing world. Now, let me talk you through what do you do as a pediatric cardiac surgeon or congenital heart surgeons. Let's look at how heart evolved in utero. It started from a very primitive tube as early as day 9 of conceptions, and then evolved slowly before it becoming a complex functioning heart with very, very important functions. And any maldevelopment at any stage will result in a structural heart lesions, which is a primary problem that a congenital heart surgeon will address, and any part of the heart may be malformed. Less commonly, there is some abnormal conductions at birth. And one of the most common reason is to congenital complete heart block due to neonatal lupus, whereby you need to implant a permanent pacemaker after birth. And based on this CDC study in the US, 1 in 4 of the congenital heart defect were deemed critical. It means that the patient will need intervention within the first year of life. And 20% will not survive beyond first year of life, as opposed to only 3% who had a non-critical congenital heart defect. And the lists are many, but to name a few, such as total anomalies from venous return, which require emergency surgery if the pathway is obstructed at birth. Let me take you through a very young patient, a neonate 1.9 kilo born term in Glasgow. With good antenatal diagnosis and care, the labor was planned in hospital. And as soon as RQ was born, he was started on prostate. And echocardiography showed coarctations of aorta, bicuspid aortic valve, ventricular and atrial defect, dysplastic tricuspid valve with moderate tricuspid stations. The plan of MDT is to provide stage treatment by addressing the coarctation of the aorta first. Preoperatively will involve consenting, planning for surgery, and briefing the team. So this is a picture of how a coarctation will look like. You can see that when the LV gives rise to the aorta, the arch becomes narrow to a pinpoint area just before the duct origin. So he was taken to theater, which confirmed a tight coarctation and extended end-to-end anastomosis were performed. And to do that, we need to stop a lower body circulation for approximately about 14 minutes or so. He did well after surgery and then was extubated. However, not all heart lesions are repairable, and therefore we may have to palliate them. For instance, let me show you a heart, okay, with a rudimentary left ventricle. So we will never be able to change this heart to a normal 2-chamber, and therefore we have to channel them down into what we call Fontan pathway, taking them typically into 3 stages of operations. The final stage being a Fontan operation, where we reroute all the systemic venous return back to the lung, typically occur between 3 to 5 years old. Therefore, if we can, we repair if possible, providing anatomical corrections. And this is true in just over 80% of patients. If not, we improve them physiologically, which accounted for just under 20% of all procedures based on our NICOR database. If neither is possible, then mechanical circular support or heart transplantation may be required, as already presented to you by Mr. Doshi. So this may be for end-stage congenital heart disease or cardiomyopathy refractory to medical treatment. This is a Berlin heart, specially designed for a small baby, okay, a very miniature device. This allows the baby, a child, to mobilize in the cardiac intensive care in a ward. Very important, allow them to extubate, prevent decondition on the bed, and allow them to physically prepare for heart transplantations. So this when the heart transplant, a donor heart arrived, and the patients went to the theater to receive a donor heart. If we can, we repair anatomically. If not, we improve the patient physiology. And heart transplant accounted well under 1% of all procedures based on the NICOR database, and greatly reduced by the shortage of the donor, especially in the pediatric populations. I'm also going to take you through some of the unique characteristics of the field of congenital heart surgery. First of all, we have to look at the wide range of sizes, from a neonate to an old adult survivor. We also have to deal with a wide range of physiology, from pink to blue baby. and also balancing the systemic and pulmonary flow, which often require a very, very delicate ICU care with very, very precarious hemodynamic in the intensive care unit. It's also a care for lifetime, require lifelong follow-up with multiple reoperation. Surgery can be diverse. Combinations is common. It may need to be staged before full repair. Operation can be long and complex. There are many collaterals which impair the visualizations, perfusion of bypass, and also cause bleeding issues after surgery. And quite often, we may encounter rare anomalies. And multidisciplinary input is critical in every stage of care. Let me illustrate that by giving an example of a young man, 22-year-old, who presented recently, just about 3 weeks ago, called James. He was born with a transposition of great arteries, which means that the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. Now, the standard operations for a transposed great vessel will be arterial switching the pulmonary artery and the aorta around. But because of coronary anomalies, he had an atrial switch operation instead when he was a neonate. However, the atrial switch procedure did not give him a good result with a buffer leg, and therefore at the age of 3-year-old, he underwent a conversion from atrial to arterial switch with the right ventricle to pulmonary artery conduit. He then had conduit operations at 11-year-old, and at some point in his life, he also needed ECMO. And just about 4 years ago, he underwent mechanical aortic valve replacements and a replacement of RV to PA conduit when he was 19-year-old. Having gone through so many operations, James actually did pretty well. He had grown up to be a well-built young man and working at WHS Smith. And my predecessor who took him through this number of the 4 major operations have done and experienced a good job for him. This is a CT scan last year which shows aorta and large aorta. The conduit just under the sternum. Conduit that go to supply the right lung and the left lung. Well-patent conduit with low estimated right heart pressure on echo. However, just about 3 weeks ago, he presented to his local hospital with breathing and chest discomfort. An echo was performed, and subsequently an urgent CT scan was done, which shows that there is what looks like a large aortic hematoma compressing the conduit just under the sternum, resulting only a slit-like blood flow from the conduit into the lung. So essentially, his lung supply was dependent on this small slit of blood flow. I received a phone call from the duty cardiologist, adult cardiologist, on late Friday, showing me the scan. He was then blue lighted to the Regional Cardiac Center in Glasgow. So we convened an emergency MBT comprising of the cardiologist, heart surgery, the mechanical support team, anesthesia, ICU, and the perfusion team. And there is no choice but to take him to theater on the same evening. We met with the family and take a high risk consent for emergency surgery. Intraoperatively, we found a contained rupture of the aortic pseudoaneurysm. The conduit was severely compressed and adherent to the chest wall. He underwent a phase sternotomy, first putting him on the femoral bypass and repaired the false aneurysm and replace the conduit. All this require a period of deep hypotensive circulatory arrest under 22 degrees Celsius. Operation was long. We started about 10 p.m. and didn't come out from theater until about 8 a.m. next morning. Post-operatively, it was not easy for him. My colleague had to take him back to evacuate some clot. He was again heparinized for his mechanical valve, and he bled again from his chest wall collaterals, and I have to take him back for re-explore and clear all the blood clot from his stem. from his chest. He's now slowly recovering in the ICU. In the field of congenital heart surgery, we sometimes encounter rare anomalies, probably I prefer to call unique anomalies. Let's take a look at Lucia, who is a unit born with 3.8 kilo. She presented with a postnatal with respiratory distress, associated with rare aortic arch malformation, which is hypoplastic. You can see that this is an ascending aorta. A normal aorta will go to the left side and go straight down to the descending aorta. You can see the trachea is here. And you can see for Lucia, she got what I call a miriform circumflex arch that go around behind the trachea, compressing on the trachea, which with a hypoplastic segment before descending into the right side of the spine, forming descending aorta. And there is a ductal ligament here, which form a complete vascular ring. So it's very different from the usual coarctation that I just showed you in the earlier slide. In order to do this, we have to use a unique approach, mobilizing all the descending aorta and translocate the descending aorta and repair that to form a normal left-sided aortic arch. Sometimes congenital anomalies can present at older age, such as this young professional footballer from Aberdeen Football Club. Aberdeen's football FC is actually one of the leading football club in Scottish Premier League. I think now at the moment they are third on the Premier League. So this young professional footballer was screened as part of his professional medical screening program. He was found to have an anomalous left coronary artery. So there's an aorta, there's a pulmonary artery. So the coronary artery, the left coronary artery, is originating remotely from the pulmonary artery at the point that is furthest to where it should come from the back of the aortic root. So we contemplate a number of options. So the left coronary artery is supplied by a large collateral from the right coronary artery. The coronary artery itself is very large, as big as 10 millimeter. So placing a coronary artery bypass graft or cabbage may not be a long-lasting solution because of competitive flow from the right side. In order to correct this, traditionally, we reimplant them. Okay, this is an anomaly that we call Alcaba, okay, and usually presented in a baby. So, and commonly they arises very close to the aortic root. However, because in an adult, the pulmonary artery is so big, and with a remote origin, there's no way it can reach here. And the Japanese group has described using a Dacron prosthetic tube to reach the aorta to restore native flow. However, this may not be a good solution for a young professional footballer who is very, very active in his professions. Therefore, we use what we call a free aortic graft technique to form a new pathway, an autologous pathway to restore antegrade coronary flow from the aorta to the left coronary artery. Therefore, in congenital heart surgery, you may encounter unique anomalies that may require unique approach to achieve optimal result for your patients. Now, we are here today because we have stood upon the shoulder of giants. And thanks to the mentors and pioneers in congenital heart surgery. And the two most influential mentors in my careers in the field of congenital heart surgery is Saif Hassan from Freeman, Newcastle, and also David Campbell at Children's Hospital, Colorado, Denver. They are great surgeons, great role model, great aspiration to me, and great mentor who teach you many things in surgery, but also in life, and generally care for the trainees. This is Dave. He is one of the pioneer in the very first description of novel operation back in 1981, which was conceived by Bill Noble, who is now retired. Aldo Calcender, who is a legend in Boston children in the field of pediatric cardiac surgery. He's now written to Guatemala. And Dave Campbell in Denver. Dave also was the first surgeon to perform a DCD heart transplant. As mentioned to you by Mr. Doshi before, this DCD transplant was first described in a pediatric patient in 2008. The first author, Mark Boucher, is a transplant cardiologist who unfortunately died from pancreatic carcinoma. Now, we are here also because of the work of the pioneer. Human heart was once considered an surgical untouchable organ. And as such, Professor Bill Robb, a renowned professor of surgery, has said this: if you touch the heart, you lose the respect of his colleague. But now, I think we have gone, miles from that. And let me just take you through a few examples, of the landmark in pediatric cardiac surgery. So this is the first successful publication in Trajafalo back in 1944. The first patient was Eileen Saxon, 15 months, nearly died from cyanosis or cyanotic smell. So this is a team who performed the first, what we now call a classic Blalock toxic shunt. The subclavian is turned down into the right pulmonary artery to give accessory flow to the lung. This named after Dr. Alfred Blalock, Helen Dorsey, and Vivian Thomas. Helen Dorsey conceived the idea and then previously asked Robert Gross in Boston. However, she was turned down and she approached Alfred Blalock to perform the operations. The first successful open heart surgery was an ASD closure under total body hypothermia. The first was successfully performed in Minnesota in 1952. And this is how it was done. The patient was essentially immersed under the ice bath to cool the whole body temperature down before the surgeon quickly worked on them. There's also cross-seclusion technique that's mentioned by Mr. Zamboa by Ward Lily High. This is the first operation in Minnesota in 1954 to close a VSD. And these are patients, she's called Pamela, on her bicycle 7 weeks after her open heart surgery. That was back in 1954. And of course, cardiac surgery today is mostly done on the heart-lung machines, and the modern theater will look like this. And this would not be possible without John Gibbon, who first described it in early 1950 and performed the first successful repair in 1953 using his machine to close the ASD. So this is an extract from a movie, I think one of my favorite movies, which I've shown in my previous presentation before.
Blood pressure 68.
Yes, go on.
Watch the carotid. Yes, traction on the suture.
Okay, now the clamp Vivian made.
A clamp?
The one just there. Right here. Yes.
We're about to connect the shunt.
Blood pressure 60. No, 59.
I know, I'm almost there. Now, front interrupted.
Good. That's good, doctor. That's good. Just a little more now.
removing the bulldog clamp.
I see some bleeding there.
I know, I see it too. Suture. Suture.
No, doctor, the other way.
Yes, yes.
Good, got it now.
Bleeding controlled. I'm palpating the connection.
What do you feel?
I can't tell if blood is flowing through the shunt. It's just too small to feel anything.
Dr. Blaylock, you have to see this.
Oh my God. My God.
Her blood pressure is rising.
Evacuate the blood of the chest cavity, Bill. Put in the chest tube.
Really filling the left lung with oxygen?
Ready for closure.
Yeah, that's one of my favorite movies of all time. And of course, the news came out in the press, saving our doomed blue baby, which had no hope in the past. In summary, congenital heart surgery is a rewarding career, and it's also a humbling privilege to be able to operate on the children's heart. From surgical viewpoint, we prepare for a long journey that can be unpredictable for your patients. Always have plan A, B, or C. We prepare for ups and downs, and the separation between hero and zero is just a thin line. Be resilient and be humble. And this is true for those who aspire a career in congenital heart surgery. We prepare for a long training, okay, with an uncertain outcome, but have a backup plan is an important advice. Be prepared for up and downs along your training. Be resilient. Be humble to learn from your mentors, your colleagues, and also from your patients. Let me just finish up by giving a couple of advice. I think before becoming a cardiac surgeon, first and foremost, be a good doctor. And whenever you're in doubt, always think what is the best for our patients, and patients should come first. And to be a successful cardiac surgeon in any field, it's very, very important that you must build a strong foundation in your cardiothoracic surgical training. And for me, I'm very privileged enough to receive excellent training in excellent units such as James Cook Hospital under the leadership of Mr. Simon Kendall, in the Freeman Hospital, and in the Sheffield under late Pradeep Sarkar, and of course the conjugate training in Freeman Hospital as well as in Denver, Colorado. Thank you very much.
Ed, that was really a really honest reflection of your specialty. Thank you very much for sharing that with us. I wonder, could I pitch some of these questions to you? I'm conscious about time, but I think they're really interesting questions. So question number one, it's anonymous. It says, I've heard that surgeons have limited contact with their patients before surgery. Can you tell us just a little bit, is that true for pediatric heart surgeons? How much time do you spend getting to know your patient before you operate on them?
Yeah, I think that's a good question. I think you must always make time for your patients. And for pediatric, you must always make time for the family. I think you need to spend a lot of time to take them through. I think that's probably one of the most important part of the patient journey, and prepare for all, I think, all the eventuality, okay, and prepare for up and down for the family. As children who with complex heart surgery can sometimes, quite often require a long road of recovery.
And as a congenital surgeon, do you perform interventional procedures such as percutaneous closure of ASD, or is that mainly done by your cardiology colleagues?
That's correct. It's only done by a cardiology colleague. Of course, sometimes we are on standby if any problems.
Super. And someone else wants to know, why does a failing Fontan sometimes need both a heart and a liver transplantation rather than just heart?
That's a good question. I think you're zooming straight into very subspecialized fields. And I think before you zoom into any congenital heart surgery, gain a strong foundation, gain a good knowledge in cardiothoracic. But to answer that question, Fontan can be associated what we call Fontan associated liver disease. Okay, I think it's a complex physiology, and I think if you meet a certain criteria of liver impairment, then you need both heart and liver transplant.
Yes, absolutely. So it's because of failing heart failure that results in liver failure. So it's a special subset that require both. So talking about, you talked to us about Al Kappa, where the left coronary artery comes off the pulmonary artery rather than the aorta, and you described that really well. But someone wanted to know, how can that present so late in someone who's already a footballer?
No, that's correct. He was essentially asymptomatic, but thankfully he was screened, and found. I think diagnosis incidentally. Of course, I think if not found, maybe a few years down the line, he might collapse on the field. Now, I think one of the important things is that in children or young people who have a congenital heart disease, they form collateral blood supply. And of course, these patients had a collateral supply from the right coronary artery. And also the patient that I presented earlier with a severely compressed conduit, he was able to survive with just a thread of flow through his conduit because he's actually got a lot of collateral supply from his aorta directly to the lung.
So then another interesting question, have there been any advancements in identifying congenital heart defects in utero? And can you plan for this or be ready to operate when a child is born?
No, that's a very good question. Yes, but I think the field is still evolving. There is, the antenatal diagnosis is pretty well established. Field intervention is just at the beginning. Okay, for instance, if we got a patient with a critical aortic stenosis, where fetal intervention can be considered, such as ballooning the aortic valve, with the hypothesis that if you open up the antegrade flow of the aortic valve, then perhaps you might prevent the formation of the hypoplastic left heart syndrome. And
Ed, so I obviously met you before because we were just cross paths at the end of your training just before you took on your consultant job. You spoke about the long road that there is in congenital training, and that's certainly true that it's different if you're training to be a cardiac surgeon or a thoracic surgeon. Could you take the students through just quickly, how many extra years does it take? Does it involve many more fellowships? Explain, did you really go out to seek your mentors a little bit more in congenital surgery prior to taking up your consultant job than you would have needed to do if you'd wanted to be an adult cardiac surgeon?
That's correct. I think typically the standard training will involve completing all your adult cardiothoracic training. Make sure you secure a very good training. And I was very privileged to have an excellent training. I think excellent unit, adult cardiothoracic unit. I think that's very important. And then you spend a couple of years in a good congenital fellowship training program. I think in the UK we have a program between Great Ormond Street and Birmingham, and also between Alder Hey and Freeman Hospital in Brompton and Evelina. But also because the training space is limited, quite often what I voice for young trainees is to consider their UX exam, the more center in US, and consider fellowship abroad. I think you see different world of practice. I think you just open your eyes.
Super. So just to clarify for students, that's 8 years in adult cardiac or thoracic, and then it's a further 2 on top of training before you then into your fellowship training. So 10 in total at minimum, Ed, isn't that right? It's quite a long time.
Yeah. However long it takes, if we are passionate about the field. I mean, I think typically, I mean, it take about 15 years. I mean, from when you qualify. I think hopefully, I think with the current training system, it might be more streamlined. But I've also known some very highly qualified trainees that take up to 20 years. And of course, once you finish your training, it's a lifelong learning process.
Yeah, and still a very rewarding job. I think you gave that message across very well. Thank you very much. Conscious of time, I think we'll move on, Farah, so I'll head back to you. Thank you.
Thank you.
Thanks very much, and thanks for your presentation. And I noticed towards the end you were talking about training, and you were talking about it's all about the patient, and that's where we started at the beginning when we were talking about SCTS and why we want to be surgeons. So